An 18-year-old woman presents to her family physician for an evaluation of severe headaches. She describes her headaches as unilateral, beginning with a dull and steady ache and increasing in severity to a throbbing, debilitating pain after a few hours. No aura is associated with the headaches, but they are exacerbated by physical activity and light. Consequently, the patient prefers to remain in a dark room when her headaches occur. She also states this is the 5th episode she has had. The first episode dissipated within 2 days, but the 3 others lasted 4 to 8 hours and resolved with sleep. What is the most likely diagnosis? The most likely diagnosis is migraine headache. What signs and symptoms are commonly associated with migraine headache? Migraines are unilateral in 60 to 70% of cases. The remaining cases are typically bifrontal or, less frequently, bioccipital. The pain often begins with the gradual onset of a deep, steady ache that reaches a pulsatile severe pain within several hours. Migraines can last from 4 hours to several days. They are typically worsened by movement and are made worse by routine activity. There may also be sensitivity to loud noises and bright lights, or they may be accompanied by nausea and vomiting. Although auras, which is temporary neurologic symptoms such as light flashes and zigzag lines, or numbness and tingling in the arms and face, are commonly associated with migraine headaches, they are seen in only 20% of the migraine cases. How is migraine headache differentiated from other, more serious pathologic headaches? The following warning signs indicate that a headache may be serious. Absence of similar episodes in the past. Association with vigorous exercise or trauma. It is suggesting carotid dissection. Change in mental status. Concurrent infection. Sudden onset within seconds to minutes. It is suggesting subarachnoid hemorrhage. Sudden change in the severity or frequency of a prior headache. Worse with changes in position or with Valsalva maneuver. It is suggesting a brain tumor. Valsalva maneuver is a breathing technique that involves forcefully exhaling against a closed airway. At last, physical findings pointing to potentially serious pathology include nuchal rigidity, stiff neck, which suggests meningitis, and poor general appearance, or papilledema, which indicates elevated intracranial pressure. How can this woman's migraine be differentiated from pseudotumor cerebri, cluster headaches, or tension headaches? Tension headaches are typically bilateral and are often described as a bandlike tightness or pressure, as if the patient were wearing a tight hat. Tension headaches are typically not debilitating, and the pressure waxes and wanes over an unpredictable time course. Tension headaches are closely associated with stress. Idiopathic intracranial hypertension, also called pseudotumor cerebri, is a cause of headache that occurs most often in obese women and can be associated with use of retinoids and tetracyclines. These headaches are commonly accompanied by nausea, vomiting, tinnitus, and vision changes, especially cranial nerve 6 palsies. They characteristically have positional symptoms. They will worsen with lying down and improve upon standing. Papilledema is typically present on examination, and the diagnosis is confirmed by the presence of elevated lumbar puncture opening pressure. Idiopathic intracranial hypertension can be treated with acetazolamide or topiramate. The acetazolamide decreases cerebrospinal fluid production through inhibition of carbonic anhydrase. Serial lumbar puncture, optic nerve sheath fenestration, and cerebrospinal fluid shunting are all options in refractory cases. Cluster headaches typically occur in males and are always unilateral. The pain often begins around the eye or temple, is sudden in onset, and could thus be mistaken for subarachnoid hemorrhage, and is described as deep and persistent. Cluster headaches are typically accompanied by autonomic symptoms such as miosis, lacrimation, or rhinorrhea. They are relatively short-lasting, 15 to 180 minutes, and are treated with oxygen or triptans. What are the treatments for migraine headache? Preventative agents include beta blockers, calcium channel blockers, antidepressants, amitriptyline or venlafaxine, and anticonvulsants, valproate or topiramate. Abortive agents include non-steroidal anti-inflammatory drugs, acetaminophen, triptans, and ergotamine agents. Triptans work by targeting serotonin receptors in the brain, helping to constrict blood vessels and reduce pain signals. Ergotamine is a non-selective modulator or agonist of serotonin receptors. Antiemetics are often used for control of associated nausea and vomiting, such as dopamine antagonists, chlorpromazine, metoclopramide, and prochlorperazine.